Introduction. Malaria is derived from two words, mala, meaning bad, and aria, meaning air. It is a protozoan infection caused by a parasite called Plasmodium. These organisms are carried specifically by the female Anopheles mosquito. 4 species of malaria parasites and their incubation period. Plasmodium falciparum, 9 to 14 days. Plasmodium vivax, 8 to 17 days. Plasmodium ovale, 16 to 18 days. Plasmodium malaria, 18 to 40 days. Epidemiology. Malaria affects up to 100 countries across the globe. It peaks in warm and humid regions. Specifically, a temperature range of 20 to 30 degrees Celsius and 60% humidity. Transmission. Transmission may occur from the bite of an infected female Anopheles mosquito during a blood meal, needle pricks and hospital-acquired route, known as nosocomial transmission, congenital transmission, or during childbirth. Blood transfusion. Organ transplant, especially liver transplant. Life cycle. The parasite's life cycle initiates with the vector's blood feeding, during which an infected female Anopheles mosquito inoculates the human host with thousands of highly mobile parasites known as sporozoites. To evade initial immune detection, these parasites rapidly transit the bloodstream, heading directly for their primary target, the liver. Upon arrival, the sporozoite invades a liver cell, or hepatocyte, and commences a phase of intense, asymptomatic replication. The parasite transforms internally, then enters a reproductive process that culminates in the formation of a massive schizont. After several days of silent maturation and multiplication, this enlarged liver schizont undergoes rupture, releasing tens of thousands of invasive daughter parasites, the merozoites, into the circulation. These newly disseminated merozoites immediately engage their secondary target, the red blood cells, thus initiating the symptomatic phase of clinical malaria. Within the infected RBC, the parasite begins as the delicate ring-stage trophozoite, dedicated to hemoglobin consumption. It then repeats its asexual division to form the crowded erythrocytic schizont, tightly packed with the next generation of merozoites. Finally, the infected red cell undergoes synchronized lysis, or cellular rupture, discharging an overwhelming cohort of merozoites. This mass release is the critical event that precipitates the classic paroxysms of fever and chills. Crucially, a small subset of these merozoites differentiate into the essential sexual precursor forms, the male microgametocyte and the female macrogametocyte. These circulating gametocytes represent the parasite's commitment to transmission, ensuring its return to the vector. When another Anopheles mosquito takes a blood meal, the gametocytes are ingested. In the mosquito's midgut, they mature and undergo fertilization to form a zygote. This then elongates dramatically into a motile, invasive eukaryote, which penetrates the midgut wall to form the protective capsule known as the oocyst. Within this structure, replication continues, ultimately producing thousands of new infectious sporozoites. These sporozoites finally migrate to the mosquito's salivary glands, thus completing the cycle and ensuring transmission to the next human host. Clinical features. Prodromal stage, the pre-fever warning. This initial stage is characterized by constitutional symptoms that precede the main fever cycle: a persistent central headache, unusual sensitivity to light or photophobia, loss of appetite with nausea and vomiting, and bitter taste, muscle and joint pains, myalgia, arthralgia. Cold stage, abrupt onset of chills and rigor. As the body's temperature rapidly rises, it triggers an intense systemic reaction. The patient experiences sudden, violent shaking chills and rigor, extreme paleness of the skin due to vasoconstriction, and cyanosis, a bluish discoloration, especially of the lips and nail beds, due to poor circulation. Hot stage, the febrile peak. This is the phase of maximum systemic overload and peak temperature. Symptoms include noticeable flushing, reddening of the skin, marked agitation and restlessness, and signs of central nervous system disturbance like disorientation or delirium, which is a critical warning sign in children, including severe limb or back pain. Sweat stage, defervescence and resolution. This concluding stage marks the breaking of the fever as the body's cooling mechanisms succeed. Key features are profuse sweating, diaphoresis, which is drenching the patient, profound weakness and exhaustion following the intense fever, and final resolution, where the patient's temperature returns to normal and they often fall asleep. Severe or complicated malaria, life-threatening manifestations. The identification of any of the following clinical features in a patient with Plasmodium falciparum infection signifies a life-threatening emergency demanding immediate medical intervention. These criteria are used for professional clinical assessment. Prostration, the inability to sit, stand, or walk without assistance. Cerebral malaria, characterized by unrousable coma or repeated generalized convulsions. Hypoglycemia, dangerously low blood glucose levels. Jaundice, yellowing of the skin and eyes, signaling liver dysfunction or severe hemolysis. Metabolic acidosis, evidenced by signs of respiratory distress, such as abnormally fast and deep breathing. Acute kidney injury, AKI, demonstrated by impaired renal function and low or no urine output. Circulatory collapse, shock, identified by dangerously low blood pressure, hypotension. Severe anemia, marked by a dangerously low hemoglobin concentration, confirmed by laboratory tests. Hyperparasitemia, extremely high levels of parasites visible in the peripheral blood smear. Eye management. The management of malaria is grounded in 3 phases: history, physical examination, and laboratory investigation. We establish the history of fever cycles and endemic travel. On physical examination, we focus on the key danger signs, checking for pallor, dehydration, prostration, and any features that suggest severe malaria. For diagnosis, the RDT offers a rapid screen, but light microscopy remains the primary standard. We utilize 2 distinct blood films. The thick film is highly sensitive for detection. It confirms the mere presence of the parasite. The thin film is crucial for identification. It determines the precise species and quantifies the essential parasite density. In highly complicated cases, where the parasite load is sequestered deep within the body, especially within the microvasculature of organs like the spleen, peripheral blood readings can fail us. In these situations, we may need an invasive approach. A bone marrow aspiration provides a specialized avenue to locate this hidden, deep-seated reservoir of the parasitic life cycle. Beyond this, the full blood count, FBC, offers vital supporting data. Malaria typically presents with a low total white blood cell count, WBC-TC. This is a powerful diagnostic clue as it quickly differentiates the infection from severe bacterial sepsis, which reliably causes a significant elevation in the white cell count. Understanding these laboratory nuances is essential for effective clinical decision-making. Differential diagnosis. Malaria is a great mimic, capable of presenting with clinical features that critically overlap with other severe illnesses. Therefore, before any anti-malarial intervention is initiated, clinicians must rigorously rule out essential differential diagnoses. This includes upper respiratory tract infections, such as pharyngitis and tonsillitis, severe systemic infections like pneumonia, typhoid fever, and meningitis. Other tropical pathologies such as measles, dengue, influenza, and tuberculosis, and metabolic emergencies like hypoglycemia. Treatment. The treatment protocol is based on global guidelines. The standard of care is artemisinin-based combination therapy, ACT. Here are the 5 main artemisinin combination therapy recommended by WHO. The drug of choice is 1. Artemether-lumefantrine, 2. Artesunate amodiaquine, 3. Artesunate mefloquine, 4. Dihydroartemisinin piperequine, 5. Artesunate plus sulfadoxine pyrimethamine, SP. Note that widespread chloroquine resistance means it is no longer the frontline agent. When the disease progresses to severe malaria, involving organ failure or cerebral symptoms, this is an acute medical emergency. We must abandon oral therapy and shift instantly to intravenous, IV, artesunate. This rapid intravenous intervention is the required measure to rapidly reduce the parasite load and secure patient survival. When the patient is stable, IV artesunate is then converted to oral artesunate amodiaquine to be taken for 3 days. Quinine remains a good alternative for severe malaria when IV artesunate is unavailable or is contraindicated. It is safe for use during the first trimester of pregnancy, for which it is administered in combination with an antibiotic, clindamycin. ACT has been found safe during pregnancy too. For prophylaxis and the radical cure of the hidden liver stages, hypnozoites, of P. vivax and P. ovale, primaquine is reserved. Mandatory glucose 6-phosphate dehydrogenase, G6PD, deficiency screening must precede administration, as the drug can induce life-threatening hemolysis in deficient patients. Finally, we distinguish between the 2 critical failure modes, relapse and recrudescence. Relapse. This occurs only in P. vivax and P. ovale. It results from parasites hiding dormant in the liver as hypnozoites, which reactivate days or weeks later. Recrudescence. This affects all species. It is purely a failure of treatment. The parasitemia was reduced but not eliminated, and the surviving parasites multiplied back to symptomatic levels. That brings us to the end of this lecture. For more indispensable medical education, please ensure you like this video and subscribe to the channel. Thank you for joining us.